You're listening to Charting the Future, a podcast for independent pediatricians by PCC. For more information about our software and services, please visit www.pcc.com or visit us on social media.
Hey friends, this is Chip from Charting the Future, and I'm here at the Montana AAP chapter meeting. It's the first time I've ever been to Montana. I actually counted last night, and I have presented at over 40 different pediatric events in my career and an additional 15 or 17 different chapters. But this is the first time I've ever been to Montana. I was just at the NCE last week where we got to see Sue Cressley give one of the great AAP NCE plenaries of all time. I hope you get a chance to see it. But when Montana invited me just a week later to come visit, I spent a couple days out west, and I gave a talk this morning, and I think things went well. But I'm here with my, believe it or not, my sincerely old friend, Dr. Eric Arzubi, whom we just clarified it. I've known for about 50 years, but I haven't seen him in about 39. And he practices medicine out here in Montana. He has this awesome origin story, and he has something I want all of my friends to hear about. So here we go. Eric, tell me who you are and what do you do?
All right. Thanks, Chip. And all of that is true. I still can't believe I've known you for half a century. Anyway, so again, my name is Eric. I'm a child and adolescent psychiatrist and grew up in Vermont just like Chip, but ended up in Montana about, 12 years ago. It was a pretty twisty path to get here. So I left Vermont after high school to go to college. I went to college in D.C., went to Georgetown, and I actually studied international affairs originally, thinking I'd be this highfalutin international business guy, and ended up with some interesting jobs along the way. My first job out of college was I was a reporter for 2 years. I was there's a little bit of backstory that I had a short-term job with my uncle who fired me, but one day on a different podcast, we'll talk about that. That was actually my moth story, Chip.
Oh, okay.
So
that's perfect.
So anyway, I ended up working as a Bloomberg reporter. I was Bloomberg's first Latin American correspondent. Did that for about 2 years. Then I quit that because, I learned a ton, loved it, wrote about Latin American finance, economics, politics, a whole bit, but I'm like, man, I want to, instead of writing about what other people do, I want to do stuff. I want to be the doer. So wasn't quite sure what I was going to do. I thought, gosh, maybe I'll go to law school and save the world. Didn't know, but I moved back to the States and thought I'd be taking the LSAT for law school. And at some point, my dad just kept harassing me to go get a job. So I'm like, I left the home, went to New York City, got a couple of temporary jobs, ended up working at a hedge fund. This is before hedge funds were really a thing. Worked for a hedge fund for just about 9 months and ended up being hired by Morgan Stanley, where I became a bond trader for about 5 years. So I was a Wall Street bond trader from 94 until 1999. And again, incredible experience. I'm living in New York City, making great money, single, traveling all over the world. And so had a blast. But still, I would find myself at the end of every day and often nights sitting there wondering, going, this is, on some level, this is fun. And I'm a very, very lucky person. But can I do this for the rest of my life? Is this what, we have one shot at life, and is this what I was meant to do? And I didn't feel that. And I kept also thinking about role models. And on Wall Street, I met lots of brilliant people, really, really smart people, could solve a lot of the world's problems if they weren't attracted to Wall Street. Yeah. But I never really found a role model on Wall Street where I'd say, gosh, I really want to be like this person in 20, 30 years. The only person I kept thinking about was someone Chip and I actually known about for a long time. That was my pediatrician in Vermont, Dr. Richard Narkowitz. And I really looked up to him, and he was the kind of person who, he felt kind, safe. He kind of, I remember him educating my mom about things that might be going on with us and would make us all feel better. So a lot of it through just empathy and communication, but just he was a wonderful doctor as well. And while I was kind of contemplating my next move and who my role model was, I went and visited with Dr. Narkowitz a couple of times in the late 90s, and eventually sort of talked myself into trying to go into medicine. I actually made one attempt in 1998 to leave Wall Street. That worked out for about 3 days. I had a panic attack and said, okay, no, I'm kidding. And I called my boss and said, it was not good. I called my boss and I'm like, I was kidding, I'm coming back. He's like, Arzubi, you're nuts, just fine, come back. So then I spent another year on Wall Street, miserable, and I'm like, man, I gotta try this. I'll regret it for the rest of my life if I don't try it. So I left, I went to do I went to Columbia to do my post-bac pre-medical program because I hadn't done my pre-med classes. And fell in love with the math and science, but felt a lot of pressure to kind of perform because I'm like, I better go into good med school if I made this effort to kind of quit this career, and uncovered that I had pretty terrible anxiety. And that extended the whole process by about a year, as I had to figure out my own anxiety, how to take care of it, kind of work through it. And I'm sure it ended up informing what I eventually did for a living. But anyway, finished pre-med, then went to med school. I was lucky enough to get into Yale. Well, I studied pretty hard for the MCATs too, so I ended up getting into Yale. I did med school there, and then I ended up choosing psychiatry. I would say probably in part because of what happened or what I experienced, but also while I was in medical school, I did a lot of tutoring. Loved working with middle and high school kids, their families, and trying to help these kids manage the stress of school and help them learn. And so I found something I was good at, and that was really connecting with families and kids. And so I ended up choosing child psychiatry, which meant after medical school I had to do residency and then a child psychiatry fellowship. So I finished all that training in 2013, and by then I was married, had twin girls, and we decided to move to Montana. I wanted to leave the Northeast, which, it's pretty intense, super competitive, and I'd lived through all that, and I didn't want necessarily that for my girls. So I ended up finding a job in Montana, and I had no idea what the challenges were like here in Montana when it comes to kind of mental health. When a lot of times when people imagine Montana, you think of the TV show Yellowstone, or you actually think about the actual park Yellowstone, and you think about the natural beauty, which is all true. But I often think about Montana as really, in some ways, the epicenter of the mental health crisis in the United States. Montana, for the last 40 years, has had among the highest suicide rates in the country. The other sort of in the top three are Wyoming and Alaska. And so, when I got here, I discovered all these things and kind of fell in love with the idea of trying to move the needle on this. And so I joined an organization called Billings Clinic. It's a big health system here in Montana. I ended up being chair of psychiatry for about 6 years. And that's where I really tried to solve some problems. So, for example, Montana, like Wyoming and Alaska, were 3 states that didn't have psychiatry training programs. So I started one, and now Montana's training psychiatrists. Again, hasn't solved the sort of mental health challenges, but hopefully move the needle a little bit. And then we also were, when I was at Billings Clinic, we were seeing patients from, 4 different states. Actually, let me see, 5. So Montana, North and South Dakota, and then Wyoming. So 4 different states coming to us, patients in crisis, about 15 to 20 a day. And we were we sometimes would make patients wait. It was probably on average 10 hours to see someone, and sometimes people were in the emergency room for days. And I'm sure all of you know about the ER boarding crisis, and that's been around for a long time. So anyway, came up with actually borrowed a model on how to handle this and create an empath unit, also called a psychiatric stabilization unit. And we got the wait times down. We reduced readmission rates and admission rates, and again, just really loved trying to find a solution to kind of these little problems or significant problems in the continuum of care. Anyway, I left Billings Clinic after 6 years because I wanted to try something on my own and start a telemedicine practice. Telemedicine in a place like Montana is vital. It's critical. For those of you that maybe don't understand the size of Montana, you can fit 27 Connecticuts in Montana. And there are only 1.1 million people, while there are about 3.3 million people in Connecticut. So you can imagine the distances people have to drive for care. So started Frontier Psychiatry. It's an all-virtual practice. We started initially with a goal to make psychiatric care available anywhere in Montana. By 2023, we were in all 56 counties, and that year I decided to look for some additional funding. Me and my partner, psychiatrist, are still majority owners, but we got some wonderful investors to help us fund an expansion into other states with similar problems. So we're in Idaho and Alaska as well. Hope to expand into Wyoming this year. But again, our mission really is to deliver high-quality psychiatric care, and we really feel strongly that you should be able to access high-quality care regardless if you live in New York City, Denver, or small-town Montana. And so that's been our mission. We serve children, we serve adults, we do serve primary mental illness, but also primary substance use disorders. Anything in the DSM we feel strongly we should take care of. kind of a long story. Appreciate your patience, but it was kind of a windy road.
So I know my listeners are sick of the hedge fund to child psych path. That's like the 8th person like this I've spoken to. No, but actually, it is what's funny to me or interesting to me is I check out all my friends from high school and from growing up. Eric and I did tennis and swam together. And I found Eric on LinkedIn, and I looked at this storyline, and I'm just like, how have I not run into him? Like, how have I not run into you doing what I do?
Right.
And what makes it really poignantly funny for me is that, as many people know, that Dick Narkowitz, that practiced Timberlane Peds, that was the first PCC client ever.
I couldn't believe when you told me that yesterday.
Yeah. And he actually, he said something to John Canning, the guy who started PCC, that John repeats all the time. It's a mantra at PCC. He said, take care of the kids and the money takes care of itself. And so we've always operated on do the right thing and the rest of it falls into place. And that
was Narkowitz?
Yes. And that was, and it's crazy the seeds he planted. Like, if you think about it. Like,
yeah.
And here you are, sincerely saving kids' lives in Montana, because of a conversation you had and something he recognized in you and you recognized in him as a kid.
Yes.
In Chittenden County, Vermont.
Yep. He was my doctor since I was 9 months old.
Okay.
He's known me as an infant.
Right. That's crazy.
Yeah.
All right. So anyway, I love your story. You can find you. I mean, people can find you on Frontier Psychiatry. Yeah.
Sorry. Yeah. The organization is called Frontier Psychiatry. Our website is frontier.care. Frontier.care. CARE.
Yep. And I mean, I remember you did this. You did all that stuff pre-COVID.
Correct.
So back when doing telemedicine was cutting edge, and then overnight we all had to learn it.
Right.
But you were already there, and there's nothing magic about Montana. Your model could be used anywhere.
Correct.
And yeah.
Well, actually, there is.
Oh, there might be something magic.
Well, no, there's no magic. But what I will tell you is Montana was actually perfectly set up to do this. There are actually probably in 2019 when we started Frontier Psychiatry, there are probably only a few states where it would have been easy to do. Montana being one of them. Here's why. Montana's been actively doing telemedicine actually since the early 90s.
It's just necessity.
Right.
Yeah.
So since the early 90s. So, for example, there's something called the Eastern Montana Telemedicine Network that's been around since the early 90s. And so Montana in some ways was a pioneer in telemedicine. And so when I arrived in 2013,
infrastructure was already
correct.
there. Yeah. This was never going to happen in Connecticut first.
No, not at all. And so I was doing telemedicine since 2013.
Well, and your specialty is really aligned with it.
Correct.
And so, anyway, that sort of, I don't know what to call it, concurrence is amazing.
Yeah, no, the fact that all these things kind of came together, and because it was such a necessity in Montana, the regulations and the laws around telemedicine were pretty supportive. So, for example, there was payment parity, so insurance companies were required to pay.
Giant. Wow. Okay, I didn't realize that.
Yeah.
So yeah. Okay.
So this was before COVID, and so So this COVID just was this huge turbo boost, right? But now because although Montana was set up for this, I felt strongly back in 2019 Montana was not doing nearly enough of it.
I mean, of course. No one is doing enough of it.
Right.
No one's doing enough of it.
And this is true for providers, because providers, and still, now it's less so, but back then, when I was like really pushing hard on telemedicine, half the psychiatrists I would talk to would be like, well, it's not the same as in-person care. And I'm not saying it is,
but it's better than nothing.
Well, that's the thing. The biggest problem is people compare telemedicine to in-person care, and that's absolutely the wrong thing to do. You have to compare it to the alternative, which is nothing.
Right. Or incomplete or inconsistent.
Correct.
Totally. And you know what I'm going to say is it strikes me, I think, that you brought a mentality to solving the problem that you probably gained in your hedge fund time. Like you brought... You look at the system and say, oh, well, we can solve this way. Whereas what I see repeatedly in our business is just people try to solve things by breaking as few rules as possible.
Yes.
And that's a very pediatric way of approaching. That's a very clinical way of approaching things. First, do no harm.
Yep.
And you're like, well, we're doing harm every day.
Correct.
Let's flip it around. How do we break things to make this happen?
Right.
Yeah.
Well, I think you nailed it. I think to your point, and again, respectfully, it's not just pediatrics. I think it's all of medicine, right?
Absolutely.
In all of medicine, nobody likes change, right? We doctors. I mean, here's what I think. Obviously, there's good and bad to the path that I chose, which is, I ended up finishing all my medical training when I was 44, but I wasn't born and raised a doctor. And so what that means is I maybe had a different perspective, and to your point, I looked at the problem differently, and I was really worried that. So in medicine, it seems to be that, number one, like you said, we do no harm, follow all the rules, right? Because if you want to go to medical school, you better follow all the rules in high school, follow all the rules in college, follow all the rules in med school. So you're not trained to be creative. You're trained to follow these rules, algorithms, and so forth, which works to a point. But if you want to solve big problems, you can't think that way, because what is really bothersome to me is that I feel like, at least what I've seen in mental health, is like we keep trying to solve this big problem using kind of the same templates from 40, 50 years ago.
You can't.
You can't.
Especially because the problems they were solving 40, 50 years ago are not the problems.
Correct.
Yes.
And our tools are different.
Right. And that's a very quant perspective. It just is.
Yeah, no. Yeah. But that's the thing. So you look at all the data, right? And the other thing is what we're often lacking is we have a sense of urgency. We don't have a sense of urgency, sorry. So what we'll do is, hey, let's have a task force, let's have a committee, let's think about it, let's study it. Well, I can save people a lot of time. We have a problem. That's been established.
Right.
We have a problem.
Yep.
The other thing I would tell you is that, and I actually use these words that I'm trying to stop using, and I said we have a mental health crisis. We don't have a mental health crisis. We have a chronic system problem. They've been calling it a mental health crisis for the last 25, 30 years. The Surgeon General in 1999
declared.
Yeah. And so I don't think we can call it a crisis anymore. Like, this is...
Yes, it's endemic.
Correct. We've created a problem,
and
we've chosen not to solve it.
Yep. And if we only had another couple hours on this podcast, we'd solve the problem. But
correct.
So you guys now can hear why I wanted to talk to Eric. Everyone who knows me is like, oh, I can't believe you haven't had him on a podcast before. All right, so let me switch gears a little bit.
Yeah.
What's keeping you up at night right now? I mean, besides the obvious, right? Like, what sort of things, by keeping you up, not only because you're worried, but because you're contemplating a problem.
Mm-hmm.
Yeah. So what's keeping you up at night?
So again, number one, well, I don't know if I start numbering, I'll forget what the numbers are. So I'll just say, so one of the things, like I just mentioned, is we need to have a sense of urgency to solve these problems. We do not have a sense of urgency. Again, when we're sitting there having meetings about this stuff, I guarantee you 2 blocks away, there are people in crisis who want to die and want to kill themselves. We need to be thinking about those very people. Don't just think about, hey, the people who want to save next year or 2 years from now. So we need to have a sense of urgency, number one. Number two, like we were alluding to, we have more and more and more data. We have more and more and more tools. And so we have the ability, if we really wanted to, if the right people took leadership and really grabbed this problem, by the horns, we could be risk stratifying all our patients with mental illness. Like, we could be doing really deliberate and proactive population mental health, where you look at your panel of patients or a systems patient panel and risk stratify by acuity of mental illness. And guess what? The highest risk people, you call them today, and you get them in today. You don't wait till they show up in the emergency room. And then, so again, you can risk stratify, do some more predictive analytics, and do proactive care. We can do that.
We don't even do that for viral illnesses right now.
But
I agree with you. It's like it's right there.
Yes, we have the data.
Yeah, it's right there.
And the power of the computational power we have is increasing exponentially every year.
Yep.
So how the heck are we not doing this? Mm-hmm. Certainly mental illness, and if not all illness when we're talking about population health.
Yep. All right, that was 2. Did you have any more?
Do I have any more? What else keeps me up at night? What else keeps me up? Gosh, a lot of things. Some personal things, some work things. But I would tell you those are kind of the biggies. And the other thing is, I would tell you that I feel like just kind of in general about the work that I do, like, 5-6 years ago, it was enough to say, hey, I can give you access to care. More recently now, you need to be able to have access and quality, and you have to demonstrate and prove your quality. Yep. And it's not enough. It's not okay for we people in mental health sometimes, and we do this, and I don't like it at all, is to say, well, you can't really measure what we do.
Yes, you can.
Yes, you can.
Yes, you can.
Dude, we publish 10,000 to 20,000 peer-reviewed mental health papers every year. We must be measuring something,
right?
So we can measure that stuff. So again, initially you could get away with. Go ahead.
If you can't measure something, how do we know we have a crisis?
Well, exactly.
Just by feeling,
right?
Like,
exactly. Clearly, we're measuring something,
right?
Right. That's a great point, right? So the number of suicides tell us we have a crisis. So let's use that as a measure.
And that's a pretty good one.
That's a great KPI, right? So again, initially we could get away with just providing access. Now we need to do access and quality. Next step, we need to do access, quality, and value. And a lot of times in mental health, and I'm sure in a lot of different medical specialties, is we're going, my goodness, we're not getting paid what we're worth. Well, it's up to us to demonstrate our worth.
Right.
We need to demonstrate to payers, to society, the value of what we do every single day.
Yep.
And so one of the things we're trying to do is exactly that. It's like, I can't just go and beg people to pay me more. Or pay us more for the services that we deliver. I need to prove to people that what we deliver is worth it.
I run into all the time the problem that pediatricians don't like talking about themselves.
Right.
They're really bad at self-promotion.
Yep.
And if you say to them, I point out, well, without pediatricians and, let's say, elementary school teachers, the United States doesn't go back to work after COVID. Pediatricians saved the United States because they did all those labs, they saw those kids, which meant kids could go back to school.
That's a great
point.
Which
parents can go to work.
Great point.
I lay that out, and they're like, "Oh yeah, I guess you're right." And I'm like, "No, you need to understand. Right? You need to stand up and scream.
Start posting about it. Right?
Without me, our town doesn't go back to work.
Yep.
Without these 4 practices, our county doesn't go back to work. Without this county, this state doesn't go back to work." And it's okay. It is the pediatric nature. It's your pediatric zeitgeist to be humble.
Right.
But you've got to take that hat off sometimes in the scope of everything else we have to worry about and say, no, taking care of kids is really important because it has a huge impact on all of us.
Correct. Well, to your point, so maybe instead of calling it, not saying because you called it, but they maybe need to think about it as, instead of self-promotion, it's advocacy.
Right.
It's advocacy.
It's advocacy, and they're not, and they're good at that, but they really want to use everyone else as an example. That's right. Like they don't. Anyway.
That's so funny.
Okay. So, all right. What's exciting you these days? What are you looking forward to?
So first of all, I think, again, it's so easy, and that's why I go back to kind of the fact that I hate that we call this a mental health crisis. We have it's an endemic problem. Our system is just broken. And so if we can get away from the idea that, oh my God, we have a crisis, right? Because when you have a crisis, like you can get away with doing nothing because, it's such a crisis, it's too hard. Well, wrong. We actually have tools to solve most of the problems we're sitting here talking about. Mm-hmm. If you go to the research, right, we know how to take care of anxiety. We know how to take care of depression. We know how to take care of people who've been exposed to trauma. We know all these things.
Right.
We are terrible at executing. We are terrible at disseminating. We are terrible at deploying these things. Mm-hmm. And so I think what we need to be doing is, number one, there's hope because tools exist, and we have solutions to a lot of these problems. We just need to acknowledge that we're terrible at executing and deploying these things. So perhaps the research we should be doing is, instead of trying to find the next new gene or the next new receptor for the next new medication, if you can get Prozac dosed at the right amount in rural Alaska, forget the new gene.
Right.
Like let's just do the basics right. And so why don't we study how to best deploy interventions? And so, like every paper that we publish, at the end of it, we should actually show and talk about how we're actually disseminating these best practices
and what the value is.
100%.
And how much could this save? I never thought of that.
Yep.
There should be that should be the footer of every paper.
Right. How you disseminate it? What's the potential ROI? 1 year, 5 year, 10 years, and that way you start helping organizations. Right. And
that would also let you prioritize papers or prioritize interventions.
Yep.
Look at that. We just solved healthcare.
There we go. That was easy.
All right. Well, anyway, thank you very much, Eric. It's been good to see you.
You too.
Keep up your good work. It's frontier.care.
Frontier.care, yeah.
I'm telling everyone, go check it out. It is really that cool. And
wait, but you forgot to tell them I'm a massive presence on LinkedIn.
Oh, okay. That's right. No, we were joking about that. It's true. Wait, how many followers do you have right now?
I actually have 45,000
That's real. Those are real numbers. How many are bots that you paid for?
Half.
Yeah. Still, 20,
Yeah,
22.5. That's pretty good. Well, thank you, Eric. I appreciate it.
Thanks, Chip.
Thank you for listening. More information can be found in our show notes. Production and editing by Chip Hart, Ali Squires, and Chris Forleo. Music by Challenger C. I'm Mark Herney.